So thank you everyone for staying for this last talk. There will be slides of cartoons, so it's quite hopefully a much light-hearted one compared with our previous presentations. I just want to introduce myself a little bit more. I spend most of my time at Peter Mac working both with the patients upstairs with cancer, with the normal team, but I'm also lucky to be embedded within the familial cancer clinic now for the last 6 years. A lot of people sort of get a bit worried that there's a psychiatrist in the familial cancer clinic. Why do I have to go see the psychiatrist? But really it's easing access for the patients to see someone if they do need psychological support. From the hospital's point of view, a psychiatrist gives the full range of the talking therapy as well as the medication therapy if required for these patients. And because I'm part of the team and we may be likely to see these patients for a long time over their lifetime, just like yourself, there's this familiarity with that person and they may be more likely to come and see me, which then helps the team, of course, get them to do what's required of them in managing their cancer risk. So I'm not here to tell you how to treat your patients, or obviously you know how to refer to a psychiatrist, but maybe just to shake up that idea of when do I refer to a psychiatrist or someone who works with a familial cancer clinic. Because often the situations that present where I see the patient, you're probably trying to deal with yourself in your practice. So jump in at any time if you want, if you have any questions about what I'm saying as well. So the topics I'll cover is first some general ideas about issues that come up for patients who present to the clinic, and then also what we might be screening for in terms of psychological adjustment for these patients, and then they get referred to me, and then issues that come up after they've had their result, and also during any prophylactic treatment they might have. I'll then tell you what kind of support services we have at the Peter Mac, and that might be a point in time where you think about, do I have access to such people in the community? Unfortunately, our services at Peter Mac are only for patients at Peter Mac, but there are a few psychologists and psychiatrists out there who are happy to see these types of patients. And then I'll have about 4 or 5 case vignettes, which just illustrate to you the types of referrals I'm happy to receive, and what I do for them. And again, maybe this is something that you might have had to come across in your time in your GP practice as well, and whether we can discuss what to do with these patients. So the first ground rule is when a psychiatrist says it, it's not considered psychobabble, but it's just a joke, okay? All right. So most people, I don't know how much exposure you do have to people who are considering genetic testing or who have had genetic testing. I can say up front right now, most people will do fine through that process, but it is a big process for someone to decide to call up a genetics clinic, have the history taken, go through all the testing, and then they may or may not have to deal with the consequences of that test result. So there are common issues that come up for these people. And up to 25%, depending on which study you look at, up to a quarter of these people will describe significant symptoms of distress, anxiety or depression, which can affect their functioning at home or in the workplace. So not very different perhaps from other situations where, again, if someone has to deal with a significant psychological event. Some of these points are quite obvious. Those who self-refer seem to have higher distress levels than those who've gone through a healthcare professional, and maybe that's because you've already talked to them about their risks or helped them map out what's going to happen next. Or those who self-refer probably have a higher anxiety and worry about their own risk of cancer, or have a clear family history of cancer that they have put into their own personal narrative, and then therefore increase their perceived risk of cancer. Those who have children are more likely to come. So they talk about not their own fear about their own cancer risk, but preventing cancer for their children. There's a significant number of decliners. So looking at a few studies, about a third of people who don't have to pay for screening, so in Australia they'd be eligible for screening, decide not to come and not to go through with it. So of all the decliners, 20% of those don't go through with it because they're scared of the outcome, of how they'll deal with the outcome, and about a third of those, so nearly half of all these patients will decline because they're scared of just the whole process. And so we never get to see them, even though we could do quite well with them, but they probably come back to see you, or maybe they came to see you but then they've disappeared completely. And I suppose these are the people, we don't know how they do, but this is, I guess, a patient population that you might have to deal with and talk through, because it could make a big difference in terms of managing their potential cancer risk. There's this talk about, there's repeated findings of when people do turn up to genetic counselling, they have improved theoretical knowledge. So they're very good at listening, and the genetic counsellors are very good at explaining and communicating their risk. But it doesn't change their personal view of their perceived risk. In later slides, I'll show you that the perceived risk is often their own experience of cancers in their own family, or with some genes, it's the whole family perceived risk and the family understanding of their genes. So they can, in their session with me, they can very happily say what the geneticist or the genetic counsellor told them, but then my next question of, so how do you feel about it in terms of yourself? I can get a completely different story as well. And of course that mismatch with the intellectual understanding and the emotional understanding is where my work is. And then one area that again is sort of a bit unexpected is you'd think people who had a negative result were quite happy, and as happy as those with a positive result, but actually a lot of patients with a negative result can then feel survivor guilt, or that this is wrong, you've got the results wrong, I'm sure I have a cancer risk and I'm coming back for a screening no matter what. And of course the ones with an uninformative result, they probably find it the hardest, because now there's no clear pathway for them. What is there for them? What can they do with their perceived genetic risk or a little bit of theoretical risk? So those are sort of how they present. The genetic counsellors will screen for people that they consider may be at elevated risk, may turn out to have some of those issues during their first couple of assessments with the patient. And again, some of these are really obvious and probably are risk factors for distress in any other setting, such as if they have a psychiatric history, if they have current symptoms of distress or anxiety or depression. The perceived risk I've talked about already, and that is something that definitely the genetic counsellors talk about, but maybe again that's how they would present to you as the GP. A person who lost their parent, usually a mother, when they were quite young, are ones who present with a lot of distress during the genetic counselling process, because often I suppose this may not have been addressed during the time of their loss. And someone who's a first member of the family who has no family narrative or history of the cancer and how to deal with it can present with heightened distress as well. As I said, most people, after they've gone through that genetic testing process, do quite well. As you can imagine, they have that peak of distress through that whole genetic testing process, which can take a few months, and then, but by about 6 months and 12 months follow-up, and now there's, I think, 10-year follow-up articles as well, they're functioning quite well, whether they're a carrier or a non-carrier. And with the different genes, there doesn't appear to be any difference really as well. But in terms of for the ongoing clinicians, whether it's at the genetics clinic or with yourselves, it's good to still remember the people who might be at risk of further distress in the future. So again, very obvious, those with ongoing unresolved grief, a more passive coping style where they're expecting things to just get better without doing anything about it, holding on to this higher perceived cancer risk, whether that's correct or incorrect, because as you can imagine, through their time, whether they're having surveillance, where they may have a scare with their surveillance, or whether there may be significant life events, so whether they're getting married or having children or some other medical issue may arise, again, because of the underlying risk factors, this extra burden of having to deal with a cancer risk can then create emotional distress that, again, either the GP or a psychologist or psychiatrist may have to help deal with. And the other area that the GPs may have to deal with in this living with a gene result is often when we've dealt with the patients with so not through surveillance but through a prophylactic treatment, we discharge the patient. So we're no longer seeing them at all in our clinic. And again, it's back to the GP who has to deal with this person. And even though, again, they've had supposedly more definitive treatment with a prophylactic treatment. This idea of having to live with cancer, even though they've dodged cancer, can persist in their thinking about themselves in terms of their health and their children's health. And the issues identified with what patients want to talk about fall under these 6 categories. And again, it's pretty obvious why these issues would come up in terms of, you know, obviously if they're dealing with cancer. A big one that lots of patients talk about is, okay, I'm trying to avoid cancer by having this gene testing and by having surveillance, but often I feel like I'm actually dealing with cancer anyway. But because I don't have cancer, I don't get the emotional support, I don't get the days off work perhaps, or sort of the help that someone with cancer might have, and that's quite a hard thing for them to deal with because they feel like they're complaining and that the emotional distress is really not worth anything. They should be coping better than someone with cancer. The practical issues is pretty obvious, you know, can I get health insurance, can I get life insurance, how do I get time off work, you know, to come for all the screening. Family issues comes up a fair bit with me. Often with that clear family history of cancer, people they've either talked about it or they haven't talked about it, and there's quite a few families where this idea of having something genetic that could affect everyone can be quite toxic, and families can fall apart because they don't want to acknowledge that and don't pull together to help deal with this issue. It instead pulls the family apart, and how do we deal with this? Child-related issues is often where, how do I explain to my children what treatment I'm having at the moment? If I don't have cancer, how come mummy's going into hospital to have bits removed? Or talking to adult children, how do I explain to these children their risk for them in the future? And then emotions around the testing itself. So I will see all sorts of people. This is out of order. Sorry. Some specific, I'll go back to that slide. Some specific studies around the specific genes is, or issues around the specific genes is, of course, I shouldn't write BRCA 1 and 2, it should be the hereditary breast and ovarian cancer genes. A lot of these people, of course, will go through risk-reducing surgery. And it's interesting now because a lot of people move from overseas. Different countries will have different sort of pressures on either having annual surveillance or risk-reducing surgery. And it sounds like, for example, people from the Netherlands and Canada seem to feel the pressure to do more risk-reducing surgery, whereas it appears, and this is just anecdotally, in Australia it seems like we do have more people who are comfortable with going with annual surveillance, and whether that's the health system's pressure or individual clinicians' pressure or hospitals, I'm not sure, but certainly this is the stories I get from patients where they get confused. You know, my sister in Netherlands has been told to have the operation and you're telling me not to, why are you stopping me from having this operation? And we sort of have these issues. But in general, you know, a third of patients will go for a risk-reducing mastectomy and 2/3 will go for the oophorectomy. That's probably more like the oophorectomy is probably because, you know, at some point women are happy that I don't need my ovaries anymore and they're happy for that to be removed. And also that it's an internal organ, so there's not so many emotional issues to deal with in terms of how they look and the impact on their body image and self-identity, or explaining to other people as well this surgery that they've had. And in general, again, people do quite well with these operations. In the past, maybe 10, 15 years ago, there was a huge burden of psychological distress and depression afterwards, where women talked about feeling mutilated and regretting their decisions. And based on that, basically my job came about, where people would go for pre-op assessments, where we would discuss this decision. And it seems like that the regret and the psychological burden has reduced post-operatively. Men, we don't talk about men much in these families, and there's certainly not many studies done about them as well. In general, again, their distress and reasons for distress are similar to women, but perhaps there's 2 points there that where they don't do so well is that, of course, the public messaging, the public health messaging does not really include men. So then they feel a bit silly, or that they shouldn't be seeking help, or that it minimises their risk or the risk for their children. They may not understand the genetic risk. And the other thing, which is a whole different talk altogether, is men's health behaviours, where they don't like seeking help. When they seek help, they want it in a different way from women. And so again, sometimes it may be difficult to draw these men into either getting the genetic testing or getting the follow-up psychological support if they require it. I see the other genes less often. My feeling is that with, say, Lynch or the gastric cancers, and certainly in the studies as well, there's a bigger involvement of families. There seems to be a bigger family decisions, family perception of risk seems to impact people more on their adherence to treatment and understanding of their risk. So I wonder if there seems to be less psychological, I'm not sure, because there isn't that much studies, but I do see less of these patients. And when I do see them, they seem to have a much richer family understanding of what's going on with their genes. And then the last point there, where I said before as well, those who have the less common genes for breast cancer, say like the TP53 and other ones, or variations of unknown significance, these people find it very hard to understand what to do or how to deal with the emotions, because there's less people or information to share about their breast cancer risk, or because it's a variation of unknown significance. Now what do I do? It's a very grey zone. So we are very lucky at the Peter Mac, of course, that we have a whole bunch of different programs available for patients depending on who they come through first, where the psycho-oncology program is, of course, for people who already have cancer, and some of these people, of course, will then get a gene testing during their time of their cancer treatment and then access our services. But really, all their decisions, in a sense, are quite clear-cut, because they already have cancer, we're going to have to deal with the cancer and so on, and it's quite time critical. Patients who come through the familial cancer clinic, there is not that time pressure, and so we see them over a longer period of time. We may see them repeatedly, where the genetic counsellor may say the same information over and over again for maybe 3 to 5 years, but the person is not ready yet to continue with that, with the genetic testing process, or even after they've had the test. Because of lifestyle or life events, they may not carry on with whatever is recommended, and we just continue to see them through a long period of time. So I'm not outside of the hospital. So unfortunately, yes, these patients have to. The people we see have to be patients of Peter Mac. My understanding is that other familial cancer clinics don't have such easy access to psychological services. I'm sorry, I forgot to say, our nurse. We have a nurse who also contacts the patients regularly and is part of that specialised support care service. So I'm not sure if that happens in other clinics. And there's a very few people outside of the hospitals who are comfortable with counselling or treating people with genetic risk. So I'm not sure if anyone actually refers to anyone out there. Have you heard of Jane Fletcher? Okay, so if you need people to refer to outside of the hospital setting, Jane Fletcher is a psychologist who's done a lot of research through Cabrini Familial Cancer Clinic, but she also has her own private clinic in about 3 or 4 locations around Melbourne, where she's trained up a whole bunch of other psychologists, mostly to do with cancer, but they're also comfortable with genetics as well. And in terms of psychiatrists, myself and Dana Rumbergs, who works in Kew, where we have both worked in the Peter Mac Familial Cancer Clinic, we definitely have that confidence in understanding the genetic side of things. I'm not saying don't refer to other psychologists or psychiatrists if you have ones that you're familiar with. However, that person needs to know about the genetics, and sometimes the patients really feel offended that this health professional doesn't know anything about genetics, and how come you sent them to me? And that's the benefit of myself and yourself, where you understand what they're going through. It's a very specific thing that they're going through. It's not an illness that needs to be treated. I have this extra information that can affect me in some way. You know, it's an unclear way, or my children in some way. So who is able to sort of sit with that uncertainty And yeah, it's either an embedded psychologist or psychiatrist, or someone like you who has that special interest in it. So what I'm trying to say here is, and the rest of this talk will just be 4 or 5 case vignettes just to illustrate the types of patients that I see. They're not ones with, please see, Joe Blogs with, 3 weeks of depression symptoms, prescribed medication or whatever it is. A lot of this is talking therapy. A lot of this is really, I guess, a sympathetic ear, structured problem solving, some behavioural changes if it's about changing lifestyle or changing their understanding of their self-identity and what is it like to live with a gene, which can be usually done in one session. I think only 10% of my patients I have to see for more than one session. I mean, I do sort of blow my budget a bit. I see them for like an hour and a half. I know you don't have an hour and a half to see a patient, but a lot of this can be resolved quite quickly. A lot of these people, obviously, like everyone else, like all of us, function very well most of the time. But again, this is a very big blow to themselves and their family, potentially. And it does require a fair bit of talking and mulling over. And like I said, both a GP who's known that person over a long period of time, or someone like me who I can sit there for a short period of time once off, but know a lot about them. We are that trusted insider. We have no vested interest in giving them a surgery or making them do a colonoscopy or anything like that, but we are that extra brain, I suppose, to help them think through the information so that in the end they can make that right decision for themselves. So any questions about any of that before I sort of go through my little cases? Okay. Oh, sorry, one more slide. This slide is just to point out how I might take a history differently from how we normally would think about taking a psych assessment. I still do the full psych assessment because, as I said, sometimes the referring question is not quite clear, and just because I'm a little bit obsessive, so I still do the medical history, psych history, social situation, current stresses, personality, that kind of thing, family history, social history. But I start with their personal narrative. As I said, the perceived risk, not their intellect or anything else, is the big thing that colours their whole view of any interaction with our familial cancer clinic. So I always ask, what is their experience of cancer? What happened in their own family? And I'll get that back, and they go, what, from 3, from 6, from now? No, however you want to start that story. So I get that whole chronological story before I come to their current level of distress and their current recall of what's been told to them by their GP or their oncologist or their genetic counsellor. If they're going for some kind of surgery, I'll then talk through basically extended informed consent to again double check that they have that correct theoretical understanding, but then again doubling back on their experience and what this may mean for their self-identity or body image, which can not just be the physical appearance, but for example, their role as someone who may be a mother who may want to breastfeed. I've had a few women who have been interested in, they've been quite athletic people. So in terms of having that risk reducing surgery, they've actually wanted to have the removal of their tissue, but then to have no reconstruction. And what does that really mean? And for them, it's because I'm an athlete. I don't need them, and this is better for me. I've also had men who've had which I'll talk about a little bit later, who've had their stomach removed, but they've also been very strong athletic people. And how do I continue to be that athlete, to be that big strong man without my stomach? So the classic idea of it's a woman who's worried about their femininity is not always the case. There's also lots of other people who have, because we're changing their body in some shape or form, do need to have that discussion about body image and self-identity, which again, because I suppose of, social media, can be seen as an embarrassing thing or a silly thing to worry about, but it's actually, again, impacts on their quality of life ongoing. Okay. So Anna is probably the classic and the most common patient that I see, where it's a young lady who's signed up to have the prophylactic mastectomy already in our public hospital. They often have to wait 12 months. I think the longest they've had to wait is like 2 years. quickest ever I think was 6 months. So this is really straightforward, nice one that I can finish in less than the hour that I get. So her story would, and many women's stories would be, someone in her family told her to get testing. She's a clever young woman, so she Googled it herself and understands and has heard a lot about BRCA testing, BRCA genes and what it means anyway. But she didn't want to do it when she was told at 20, I think, when she was in university. And she wanted to have children. She didn't want to think about and have that colour her decisions to have children. So she waited till she was 30, and she now has 2 kids under 3. She's married. She's got a very busy and fulfilling practice, and she's ready. She's got time now to go ahead with this testing. And she's signed up for the earliest one that she can. She's happy for, if there's a cancellation at school holiday, she'll go and have that as soon as possible. But when I asked her again, that sort of, from your viewpoint, what is your narrative, what is your understanding of cancer and your gene risk? We have this long story about how the impact, this silence, for her it was this silence about her mother's illness through all her teenage years really, which obviously can be quite frightening for a young woman. Where she did the right thing, she kept studying, she turned up to sports, she finished year 12 on time, she didn't take any time off. Her aunties helped out with the food and the pickups and the drop-offs. But when her mum died, there was no talk about it. They went to the gravesite every year, but pictures were put away. We didn't talk about feelings, and Dad repartnered the following year, perfectly, the year that she also moves out of home and blossoms. Dad repartners, and the family is intact in some way. They stay together for family events, but this big, hole of Mum and what our family is now after Mum is gone has never been talked about. And I think with a few of these ladies, one long session or a couple of sessions is required just to talk through that. Because who else is going to talk to them about it? Dad doesn't want to talk about it. I don't want this to happen to my children. They often will say that. I never want this to happen to my children. It's a bit too late now to talk to my husband about it or friends, and so I'm the person, I suppose, where it comes out. And I suppose this probably happens with GPs as well, that if you poked, it would probably come. If you had time, it would probably, you would probably get through all of this. And then once we then bring her back to the present, a lot of this sadness, the vulnerabilities are no longer there. She's a fully well-functioning person with lots of social supports. She can then put that behind and probably then get through that prophylactic mastectomy without that sense of vulnerability, and she can probably do quite well afterwards. We always offer to have an appointment afterwards if more issues arise having gone through that surgery, but most of these people don't require that follow-up. And we know that because our nurse calls them, I think, about a year, or 6 months afterwards. She still gives them a phone call just to see what's going on, even if they don't make contact with us. Slightly different one here would be Sandra. This is obviously they're all de-identified or modified in some way, where I accept referrals where patients will go, I just want to have a chat, or the nurse or the genetic counsellor will say, I don't know what's going on here, but they're a bit funny, they keep calling me, or I just get this sense they're not quite comfortable, they're just saying yes, 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 but they don't really, and they said yes to seeing you, which is quite hard sometimes. Do you want to see a psychiatrist? Yes. So Sandra is one of those patients. She just wanted to chat. Very organised, competent person who again already scheduled herself for her bilateral mastectomy. And this was in the context of suddenly finding out at a family function 6 months ago that there's this clear family history of breast cancer in the family, and that now there's this gene because her cousin had breast cancer and then found out over this gene. Sandra and her older sister both went for this test. Both of them had the gene, and sister already had breast cancer and she's currently undergoing treatment for it. Sandra doesn't obviously have breast cancer. As part of that treatment, they both had the oophorectomy, and Sandra is slated for her prophylactic mastectomy in about 6 to 9 months. But she felt really upset. She thought she could cope, she understands all the information, but why is she feeling upset? Why is she not going to work? Why is she crying? Why is she arguing with her husband? And in the end, I saw her for about 5 or 6 times over 6 months. When she felt like it, it had to be paced with her because she is clearly someone who needs control, and she was losing emotional control. over what was going on for her. But a couple of things came out. Loss of control. She had two hard choices. One is she has this operation that she doesn't want and will look different at least, and maybe disfigured. But also she never wants to have cancer. So why me? Why do I have to make this choice? Because there is some, it's in my control, but I don't want to control this. And behind that anger, of course, was fear that why would I have this gene? I'm so healthy. She runs, she doesn't smoke, she doesn't drink much, and of course she's a very capable person in every other part of her life. The fear also was a parallel with the fear that she had when both her children were born. I don't remember exactly what condition her children had. One had a heart condition and one had something else. But she was suddenly drawn back into the past. Their children are now in their 30s, where every year they had to have some kind of checkup. And knowing that she had to have some kind of checkup every year made her remember how frightened she was each year going to that checkup, that they would find something and that something would have to happen for her children. And she also had that fear for herself. I don't want any unwanted or unexpected diversions in my life at this point in time when I'm 55 and preparing for retirement and things like that. And the other bit that was threatening for her was she tends to avoid or compartmentalise her feelings. That's how she's always functioned in her life. And right now these feelings were exploding out of that compartment and she didn't know what to do with it. And so therefore she was often angry, pushing away the key person who was her support, her husband. And how was she supposed to deal with that? So over these 5 or 6 sessions, we talked through these issues. And again, like I said, sympathetic ear, doing a bit of cognitive therapy where is this the only way that you can deal with stuff? What's the other way you can deal with stuff? And then her, applying that to herself. And then her realising that with that emotional distress coming down, that of course if she had the operation next week she probably would have gone for it and done okay, but we would have had to deal with the operation plus all the anger and afterwards. Whereas we had the time and space over 6 to 9 months to deal with that before she went for the operation, such that she was in sort of her most optimal emotional state before going ahead with the operation. And I suppose I should say, depending on what type of operation you have, most people need about 6 weeks, I suppose, at least to get over the physical recovery, and then the emotional recovery in terms of the impact on the self-identity or the aesthetic outcomes, the sexual functioning with their partners, if there's a partner or concern about future partners. That really only pops up sort of a couple of months later. And so we also say, please come back. You'll do fine through the practical aspect of getting better and dealing with the pain, but if at 2 to 3 months you're still not looking at yourself in the mirror, or not touching, not even washing yourself there, not letting your partner touch you or see, which happens a lot actually, then please come back and talk to us. We're more than happy to deal with that. And again, it's like sexual side effects of antidepressants. No one wants to talk about it, but if you ask about it, they will tell you. So either they come back to me, or they go to a psychologist that you have if you're happy with them, or at the Women's there's actually a sexual counselling clinic where there's 3 GPs who specialise in this area, and you don't have to be a patient of Women's. You can just refer in. And they do couples counselling as well as individual counselling. So yes, I know there's a lot of stuff. It feels like I have again a lot of luxury of time to talk about all these things and delve into the past with patients. But I think again with GPs, again you've known them for so long that you can probably circumvent a lot of that discussion, and because you know a lot about their current situation or their past situation. And again, I do feel, and when I talk to patients as well, the GP is that trusted person who they can bring that issue to, or maybe if you bring up the questions, they're more likely to disclose to you as well. Certainly the genetic counsellors have a lot of training in counselling, but they don't have the time to do that, of course. They're busy giving the information, but also the patients feel like it's not the right person to talk to. It's sort of like seeing a specialist where they feel like I have to be good and listen, and nod, but then my feelings are to be dealt with elsewhere. And that's not the fault of the genetic counsellor, that's just how the system is set up. A couple more cases. Fatima is a young lady that I've seen a few times and I continue to see. She has had no issues with finding out her BRCA gene result or troubles with surveillance through the last 3 years now. Her problem, which is a bit more complex, is that she wants to hold off to having the operation until she has her 3rd child. She's unfortunately obese, and her fertility is affected by this. And the other part that makes it difficult for her is that she is not allowed to, she's been advised not to have the mastectomy until she can get her weight under control. So there's 2 huge pressures beyond the negative health effects of being obese, of losing weight. So that pressure on herself plus familial issues led her to have depressive symptoms, which she's been dealing with medication and a psychologist outside. So the reason she keeps returning to me is, I guess there's this undercurrent of, can we talk to anyone about me having this well, first of all, she definitely wants her baby, but she's worried about what if I can't have my baby, and then this pressure of getting to 30 or older is coming up, and how can someone advocate for me to have this operation even though I'm overweight. It's a small number of patients that we have, but they're significant in that obviously there's lots of people out there who are very overweight, and they have their heart set on having this operation. They're not comfortable with surveillance. And here this is where we're trying to recruit the GP to help manage obesity, to the point where we're not trying to get them to a healthy weight for obesity's sake, but a healthy weight to get through the surgery's sake, which sounds a bit pragmatic, I suppose, but we can't continue to see that patient for that obesity treatment. We really are relying on the GP to do that. But with these patients, there's a lot of back and forth with the GP in terms of how do we support this person in terms of the obesity, but also the psychological distress that comes around it. This is another one that really we had to go into the past, but really was not related to what she was going through at this point in time, which is the oophorectomy. But this was a case, and we do have a few of these cases where, because she's, I think, a very clever person, this impacted on her ability to accept this. No, actually your family history and personal history puts you at low risk. And sure, you can pay for the gene testing yourself, but we're still telling you low risk. I think she actually did have the test, and yes, she didn't have the genes that we are aware of, and she struggled to really deal with that. And again, being an intellectual person, the emotional side of things perhaps had not been explored for a very long time until we came across this today in the clinic. And really it was dealing with the death of her mother from ovarian cancer when she was a young woman. The last case I have is a CDH1 case, just to remind ourselves of men, and also it's not just breast but other body parts, I suppose, that impact on someone's body image and self-identity. And he also has a few risk factors for not coping so well. So Marcus was the first person in the family really to have the gene test. Again, I think I've got a lot of intellectual people actually who aren't very good with dealing with the emotions. He's an engineer, and this gene testing came out of his sister having died from gastric cancer, and this really popped up this red flag. And so then they went for testing, and he was referred by the nurse because he was annoying her. He would argue with every clinician bring papers, argue, say, why do I have this gene? You haven't proved it to me that I've really got this gene properly, and then why do I have to do this gastrectomy because there's all these bad results, and why aren't there other things that we can do? And so really there was no referral question except, can you get this guy out of my face? But this was a person who had a lot of fear and grief, unresolved grief from the sister, and then old grief from the father, because once it was only him and his sister. It was 4 in the family, 2 parents, him and his sister. When his father died, he came from a background where he felt he had to care for the family, and he couldn't care for his sister. I mean, he couldn't prevent her death. So there was a doubling of that guilt and grief. And once we got through that, it was his self-identity. He was quite a large man who did a lot of endurance sports. And he'd always been a particular weight. He didn't want to lose weight. And how can I do my endurance sports? And how's my girlfriend? He had this first serious girlfriend of his life that he was going to marry. How's she going to deal with this? No one wants a defective person. So we talked through a lot of that. And again, that was for him, because he didn't have such a nuanced understanding of his emotions. CBT worked really well. And he was very good at doing homework, of course, and came back. And really, the time that he was able to do a little talk to his workmates about his gene, where then he could then tell them how he had to change. He was an off-site engineer. We had to travel all day. So he found it difficult that he'd have to be eating in front of his colleagues or taking time out on these site visits for himself. Once he was able to do that presentation about his gene and then how it impacted on work, and I think there was some other, then he joined No Stomach for Cancer, which is a peer support group for people with gastric cancer. He decided that we didn't need to meet up anymore and that he was ready to go ahead with the operation. And so we didn't meet up anymore, and I heard back that he did very well with dealing with the operation, because with gastrectomy afterwards, of course, there's a lot of rehabilitation in terms of eating with the dietitian and changes to lifestyle. But he sailed through all of that relatively well. So I suppose in summary, as I said, most people do well. I mean, as I said, we know it's a temporary blip for most people during the genetic testing process in terms of raised emotional distress, and those who would have been distressed or more distressed or anxious or depressed about the genetic testing, you probably would know would be anxious or depressed or distressed about something else happening in their life, and those would be the ones you'd be red flagging anyway yourself. That knowing their test result is not just a once-off and that's it. Through life, as different things happen, there can be more dynamic risk factors that come along, and again, these people may present for assistance with the emotional distress. You can do that if you have time or the energy or the interest, but of course there's plenty of people who are in the hospital, well, not that plenty outside, but there are clinicians out there who are happy to see these people, and we do not need to fulfill criteria for, anxiety or depression, because most of these people don't. And that if you are wanting to sort of have that understanding of that patient, it's really helpful to get that personal viewpoint, that narrative view, as opposed to sort of that classic medical history, to really get to that emotional issues for that patient. So yeah, that's the end of my presentation.
Do you have any questions for Olivia?
All right, thank you.